Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Hi, everybody. So I'll be talking about ART in renal failure, and we'll really try to rein myself in because there's a lot out there, but I look forward to sharing what I've learned. So here's our disclaimer. I have no disclosures. And basically the way I wanted to go about this was to first talk about potential causes of a creatinine elevation in persons with HIV, then very briefly discuss the workup of creatinine elevation in people with HIV, and then last, talk about the guidelines and some of the data behind which ART to use in renal failure, recognizing there is no one size fits all. So I thought I could frame this with a case that I've had a couple years ago of a 65-year-old man with HIV, heart failure with reduced ejection fraction, obesity, and hypertension, whose last CD4 count was 391 and viral load was undetectable. And I inherited him on TAF, FTC, dolutegravir, and ritonavir-darunavir, which he had been on since 2016. And if I looked back at his baseline creatinine over the past few years, and it's really ranged from 0.94 to 1.3. And then here is a graph of his creatinine trend over the years. So then when I saw him, it had really bumped up to this 1.81 level. So using this case as a sort of place to start, I just wanted to first talk about what the HIV-MA primary care guidance recommends for creatinine monitoring. They state that the chemistry panel should be monitored on a regular basis as needed to assess medication toxicity and to monitor potential or existing comorbid conditions, that the frequency of monitoring depends on the underlying medical conditions and the need to monitor for ART toxicities, depending upon the regimens chosen, and that last, biannual monitoring for renal function and urinary abnormalities is warranted for patients who receive tenofovir. So what are some common causes of CKD in persons with HIV? And that's what I'd been thinking about with this patient whose creatinine ranged again from 0.9 to like 1.3, 1.4, and then most recently was up to 1.8. So there's the usual causes of renal failure, including non-ART medication side effects, such as NSAIDs, etc., hepatitis B or C, benign medication effect from ART. This is kind of a misnomer here. It's not actually a cause of CKD. It's a cause of creatinine elevation, tenofovir-associated nephrotoxicity, and HIV-associated nephropathy. And for the purposes of today, I was just going to focus on the benign medication effect from ART and tenofovir-associated nephrotoxicity, since really we're talking about the interplay of antiretroviral therapy and creatinine elevation. This, I just wanted to highlight, is a very nice paper, review article from 2016 or 2017, and I have reference here on a couple of slides coming up. And it goes through all the different kidney diseases associated with HIV. There's a table that's very long, and I sometimes will reference it when I'm really kind of stumped. And so with that in mind, I wanted to first talk about the benign effects of ART on creatinine, which I think most of us are quite familiar with. And we know that bictegravir, dolutegravir, rilpivirine, cobicistat, and trimethoprim, as in trimethoprim sulfamethoxazole or Bactrim or Septra, inhibit proximal tubular secretion of creatinine, which may increase the serum creatinine without changing the GFR. And so with that, we may expect a 10 to 20% increase or a 0.1 to 0.2 milligram per deciliter increase in creatinine. And that usually occurs within the first few weeks of therapy and then plateaus, and then should return back to normal with discontinuation of the drug. And so as a result, the recommendation is to check a creatinine 1 month after starting any of these medications to establish a new baseline. And here is an image that David had created at some point, and really it's working on this proximal convoluted tubule, or the PCT. Here is an image. This one, I must admit that David did not create, and hence you can see it's just got the blood on the left, proximal tubule in the middle, and urine denoted by this yellow that I chose on the far right. And I do not want anyone to remember these transporters, but I'm hoping to just sort of really convey that the inhibition is more complex than we maybe make it out to seem. There is the OCT3 and 2 transporters, and then the MATE transporters, and dolutegravir blocks OCT2. So does rilpivirine. Cobicistat blocks MATE1. Bictegravir does too, OCT2 and MATE1, and trimethoprim blocks 3 of them. So not every medication works in the same way. And I think if we think that it's a bit reductive and is not giving these medications, perhaps the respect that they deserve. So not every medication is going to act the same way on that creatinine elevation. So just kind of keep that in mind. And that's why it's so important for each patient to get that new creatinine measurement at least a month after having been on the therapy to figure out where their creatinine has gone to. And so what about if you combine ART? I think this is something I wondered what if you have somebody on a COBI containing regimen plus dolutegravir, or you have somebody on Juluca, which is the combination of dolutegravir and rilpivirine. So not surprisingly, there's not much data on the effects of combining ART that block tubular secretion of creatinine. Our colleague Raka Kumbhakar had found 2 of these articles relatively recently, and it came up in discussion in clinic the other day. And so one of them was a prospective cohort of 288 people with HIV on different dual regimens, whether that be dolutegravir, rilpivirine, or COBI-darunavir, and there was no additive effect. And then there was a retrospective cohort of 700 people with HIV, all on COBI-darunavir or Prescobix, plus dolutegravir or rilpivirine, or the combination of all of them. And there an additive effect was seen, but it really just decreased the estimated creatinine clearance by anywhere from about 3 to 8 milliliters per minute. All this to say is that there's not much out there about what happens when you combine 2 of these medications. 2, that the exact effect of combining the ART that blocks tubular secretion is unknown and really kind of depends on the receptor and depends on the patient. So no one size fits all there. Now, what about this concept of a cystatin C? I think that some of us have talked about this, and cystatin C is a lab that we can order, and it's technically a compound that is produced by nucleated cells in the body that is not affected by muscle mass or by tubular inhibition of medications, but can be affected by conditions that cause chronic systemic inflammation. When should you use a cystatin C? If you have access to it, here it's a send out for us. It takes a couple of days. It can help discern a benign creatinine elevation from a pathologic creatinine elevation. Again, because the cystatin C should not be affected by tubular inhibition of medications. And how to use it? It can be used in conjunction with a serum creatinine, but not in lieu of to estimate renal function. So I got pretty comfortable using a cystatin C during fellowship. I had 2 HIV clinics, one at the VA and one at the county hospital. And at the VA, the cystatin C was used nonstop, VAs. And we got pretty used to anytime there was a little bit of a creatinine elevation, we would just send a cystatin C, and it wasn't expensive because we were in that system. Here, when I place an order for cystatin C, there's $2 on Epic. So it's, more expensive than a creatinine. But I have felt a bit more empowered recently to start sending them whenever I'm hemming and hawing about what could be going on with someone's creatinine, i.e., oftentimes the creatinine rises more than that 0.1 to 0.2 I would expect with the ART. And then instead of actually sending off this huge laundry list of tests, light chains, etc., I'm just really going far on as far as what could be causing some renal failure, I oftentimes will be let me just get a cystatin C. And then if it's normal, then I don't have to send a further renal insufficiency workup. And so I have felt pretty happy with this recently. For some reason, I know it's not institutionally done, at least here, that much. And so I hadn't been sending it that much, but more recently I've been sending it and have found it to be very helpful and prevents me from sending more of a workup for creatinine elevation. So switching gears a little bit to tenofovir-associated nephrotoxicity, that is usually due to TDF more than TAF, may or may not reverse with drug discontinuation, and is higher risk with ritonavir-boosted medications, and really we should exercise caution when combining it with cobicistat. The use of tenofovir, whenever I'm teaching about this, can lead to any of the following 4 things: a GFR decline, proteinuria, a proximal tubulopathy, or a Fanconi syndrome. And what is a Fanconi syndrome? It's a very specific type of proximal tubulopathy that is a type 2 renal tubular acidosis that's characterized by glycosuria, phosphaturia, uricasuria, and aminoaciduria, and so is the kind of rarest of the things that TDF, or actually any tenofovir, can cause. If you suspect Fanconi syndrome, you should calculate a fractional excretion of phosphate, and I've sort of written here what to order when thinking about calculating a PFOS. And if it's less than 10%, it's normal, and greater than 20% is abnormal. And unfortunately, I find that we're oftentimes in this 10 to 20% range a lot of the time saying, what should we do about this? And it's more often due to TDF, though case reports with TAF exist. And when I was reviewing these, I think I didn't realize, previously I had talked about these case reports, but didn't realize that these individuals had previously been on TDF and had no issues, and then switched to TAF, presumably to save the kidneys or to protect the kidneys, and then developed Fanconi. So it can occur with TAF, even in the absence of it ever being an issue with TDF. So this is kind of how I think about my diagnostic workup of creatinine elevation in people with HIV. First, I consider a benign ART effect if I have any of those meds. I consider a tenofovir effect. I consider non-HIV related causes, and then I send more diagnostic workups. So did the patient recently start an ART that can lead to this elevation? And if the increase is less than 20% from baseline, then I'll tend to continue the med. I consider a tenofovir effect, which we just talked about. Comorbid conditions such as hypertension and diabetes are becoming increasingly common in people with HIV, especially with regards to integrase inhibitors. I screen for Hep B and C if I haven't already, and then I review a med list for nephrotoxic meds. And then last, if I have a PFOS that's less than 20%, the patient is not on a tenofovir-containing ART, the patient has proteinuria or high suspicion for some other cause remains, then I consider renal ultrasound, a post-void residual, and nephrology consultation. So that's that. Here is a reference as to when to refer to nephrology. Technically, I oftentimes feel that I am sending referrals to nephrology perhaps a bit more willy-nilly, and I should actually look at these indications for referral, and these are technically them if you're ever wondering about it. So back to our case. This patient then comes back, and then his creatinine is 6. He had left the clinic. I remember calling him and was about to send a safety check when I was trying to get a hold of him because he had gone home to feed his turtle and say, hey, please come to the ER because your creatinine is through the roof. So what do I do with his ART? You might recall that he was on Descovy, boosted darunavir, and dolutegravir. And so when I'm trying to go through what ART to pick, I use the DHHS ART guidelines. This is one of my favorite tables in the DHHS ART guidelines. And it is not easy to find because it is buried within Appendix B and is actually table 12. So I find I best access it either by sort of Googling ART renal failure ART guide or like DHHS guidelines, or you can go to Appendix B and then scroll all the way down to the bottom. And for every medication, it goes through the usual dose and then the dosing in adults with renal insufficiency. On the far right column, we've got the hepatic impairment too, but really we're focusing on here. And I thought that for the purposes of the rest of this talk, that we would just kind of go through some of these buckets. And instead of looking at it in table form, I kind of spread it out in just text and bullet form so that you're more familiar with this table when the time comes. And I'm guessing most of you all have used this table, but I wanted to share some of the nuances. So in general, 1, single tablet regimens are difficult to administer in renal failure. This is from the guidelines. They say that fixed dose combinations are not recommended with the following creatinine clearances. And there's a whole lot of brand names on this slide, and I apologize for that. This is what they have in there. So you'll just notice that even at very high creatinine clearances, there's certain fixed dose combinations you cannot use. And oftentimes you really are going to have to be separating out your ART. So let's take this class by class. First, NRTIs and renal failure. TAF, in general, I can push to a lower creatinine clearance. Again, I think most of you all do this, where I'll use Descovy down to a creatinine clearance of 30. If I need, I can separate it and just do TAF with a different component, such as emtricitabine or lamivudine, also dose adjusted. So I can push that down to 15. And TAF is okay to use with HD, but should be dosed after dialysis is given. Whereas TDF is supposed to be avoided with a creatinine clearance less than 60, but we can dose adjust as follows. Meanwhile, lamivudine and emtricitabine require dose adjustments with any creatinine clearance less than 50, and no dose adjustments are needed with abacavir. But I don't tend to reach for abacavir when somebody has renal failure because oftentimes I find that there is a whole lot of overlap with cardiovascular disease, hypertension, diabetes, etc. And so I'm not super eager to start somebody on an abacavir-containing regimen, especially now when we know that there are some nuke-sparing regimens or other kind of 2-drug regimens that we can use. So that's the kind of general principles of NRTIs. Can you use TAF after having TDF-associated nephrotoxicity is a question that comes up. I think after somebody has TDF-associated nephrotoxicity, I feel pretty comfortable using TAF. I tend to get nervous when I'm thinking about somebody who's had a Fanconi syndrome to TDF and that I want to use TAF later. So the best answer we have to this comes from a trial of 31 individuals who were had a prior history of tubulopathy from TDF and were randomized to either take Descovy or to continue their current ART. Their primary outcome was a urine protein to creatinine ratio. And this first trial had found that 12-week exposure to TAF did not affect their urine protein creatinine ratio. And then I think an even better sort of answer to this question comes from the next paper, the Campbell paper, which is really building upon this initial study where they took those 31 individuals on TAF and followed them out through week 96 and found that none developed glycosuria or proximal renal tubulopathy. And in fact, there's another case report of TDF-associated Fanconi that resolved with switch to TAF. So again, I feel okay with TAF after a TDF-associated nephrotoxicity, but I can't say that I feel super comfortable with TAF after a TDF-associated Fanconi, and I tend to personally avoid TAF until I get more data about that. Okay. Next classes. And really, I'm not going through everything in this table. I'm just focusing on the meds that we use the most frequently. So first, doravirine. There's no dose adjustment necessary, but it has not been studied in end-stage renal disease or dialysis. I did a little bit of a dive on that and found 6 case reports where in people either with renal disease or on dialysis. And it looks like doravirine was extracted a bit or cleared with dialysis, and that some of the trough levels fell, but they didn't find it to be clinically significant. These are in just a couple of people. And so I am nervous about doravirine in dialysis. And I know that Bob Laufelbein and I talk about this a lot, where we are kind of waiting with bated breath for more doravirine data with regards to renal disease or dialysis. Rilpivirine alone doesn't need a dose adjustment, but rilpivirine TAF FDC or ODEFC is contraindicated with a creatinine clearance less than 30, but you can give in dialysis, and then is contraindicated with a creatinine clearance less than 50 if you're using Complera. And then for rilpivirine dolutegravir or Juluca, it says that there's no dose adjustment necessary, but if it's less than 30, to monitor for adverse effects. And then lastly, with the PIs, the darunavir, ritonavir-darunavir requires no dose adjustment. Cobi-darunavir, it says that if it's being paired with TDF, that it's contraindicated if your creatinine clearance is less than 70. And so I think that's a really high creatinine clearance. I was joking yesterday that usually the lab will say creatinine clearance less than 60, and I haven't seen anyone ever report creatinine clearance less than 70. But technically, the combo of TDF and Cobi should not be used with a creatinine clearance less than 70. And then for Simtuza, it says it's contraindicated if your creatinine clearance is less than 30, but if on HD, okay to give a dose after. So general principles here are that, again, if you have anything with TDF in it, at least a fixed dose combination, there's no great sort of rule to say that you can give it after dialysis, but some of the fixed dose combinations with TAF in it say that it's okay to give in dialysis so long as it's being given after the dialysis run. And then finishing up with the ART, I want to talk about INSTIs and renal failure. If anybody is using Genvoya or Stribild, here are some of those creatinine clearances that we should avoid. And then again, in Stribild, when TDF is combined with cobicistat, we should not be starting that with a creatinine clearance less than 70. And if somebody's already on it, to stop it with a creatinine clearance less than 50. And then Biktarvy, we should not give with a creatinine clearance less than 30 if the person's not on HD. And then if you are on HD, it's okay to dose afterwards. And the guidelines state that if you're receiving it while on chronic HD, you should technically be virally suppressed. And that's based on this data. And this is, I think, kind of probably the best data we have about INSTIs in dialysis. And there was a single-arm multi-center trial of virally suppressed people with HIV on dialysis, 55 individuals who were already virally suppressed, switched to Genvoya while on dialysis, and they found that that was safe and efficacious to 96 weeks. Amongst the 36 people that completed the study, several people dropped out. And so that was why there were only 36. And then they did an extension of those 36 individuals, seeing if they wanted to switch to Biktarvy. And that's the Biktarvy extension. 10 of those did, and all 10 participants had viral suppression at 48 weeks. And then the only other thing that I could find was that there was a case series of 6 people with HIV on Biktarvy and HD who achieved or maintained suppression. Dolutegravir and renal failure. This is tricky, I think. Dolutegravir plasma concentrations decrease if there's a creatinine clearance less than 30. And so in a trial of 8 persons with creatinine clearance less than 30 compared to 8 matched healthy controls, the AUC, Cmax, and C24 of dolutegravir decreased by 40%, 23%, and 43%. Now, I think the AUC decreased by 40% seems like a lot, but in the package insert, there's no dose adjustment that is necessary. And I've kind of highlighted what they say. If you have mild, moderate, or severe impairment, but if you are INSTI experienced and you have severe renal impairment, with certain INSTI-associated substitutions or resistance, you may want to exercise caution because that decrease in dolutegravir concentrations may result in loss of therapeutic effect. And I also think about this with if I have somebody who's on a lot of cations where the potential concentrations of dolutegravir may already be decreasing. And interestingly, in fellowship at the county hospital, we used to BID the dolutegravir when the creatinine clearance was less than 30, but then it's okay to use dolutegravir and just once daily in HD. I don't do this routinely. I don't still BID the dolutegravir. I've talked with people around the nation, and other places don't do that because it's not found to be clinically significant. But again, if someone has had lots of experience with dolutegravir in the past or is on lots of cations, then it's just something that I consider or think about. Injectables in renal failure, Cabenuva, cabrolpivirine is okay. And then if you're going to do a PO cab for an oral lead-in or a bridge, there's no dose adjustment necessarily. Similarly, with lenacapavir, there's no dose adjustment necessary. And then less commonly used injectables are enfuvirtide or ibilizumab, which again also doesn't require a dose adjustment. The meds fastemcivir and maraviroc, I don't have a slide on, but fastemcivir does not require a dose adjustment in the renal failure. And maraviroc, as always, requires a dose adjustment because it's maraviroc and always needs dose adjustments. So that's that. ART in peritoneal dialysis, there's really not much out there. I personally think that ART in peritoneal dialysis is a neglected topic. And so there's this one review that includes a little bit about it, and I've included that here. One proposition is to dose to as though your patient has a creatinine clearance less than 50. And another proposition is to just consider it like HD and that it's unlikely to need supplemental dosing. There is one case report of a person with HIV who is on Biktarvy and PD who maintained viral suppression. And then acute renal failure in the hospital, which I think most of us are not dealing with. But in case you are, there's a really nice new article that came out in OFID about managing modern ART in the ICU and also potentially on the wards. And all this to say is that if somebody comes in with acute renal failure and may need a couple of runs of dialysis, it is really tricky to be sort of managing the ART there and may at times, unfortunately, require holding ART as things sort of settle out. And I don't say that lightly because I don't usually like to ever hold ART. So what did I do with this patient? With his acute rise in creatinine, I looked at his genotype, and here you'll see that he has pretty decent NRTI resistance and NNRTI resistance. Luckily, although he's Hep B core antibody positive, he is surface antibody positive as well. And so I left the Descovy realm because I couldn't anymore because his creatinine was 6. I could not do a fixed dose regimen of Triumec. I didn't want to switch to dolutegravir or pivirine because of his high level NNRTI resistance. So I ended up simplifying him to dolutegravir and boosted darunavir. And so my personal practice for ART choice in renal failure is that there's a lot of stuff that goes into it. Again, no one size fits all. I think about drug-drug interactions, absorption concerns, prior ART history, mutations, and potential future ART options. I think about their Hep B status. I think about the trajectory of their renal function. How long do I think that they're going to be with a creatinine clearance less than 30, are they going to go on to HD soon? And then what's their viral load and CD4, especially if I'm considering a rilpivirine containing regimen. And so my general approach is that when I need a tenofovir sparing regimen, I tend to use dolutegravir plus actually boosted darunavir, so either cobidarunavir or ritonavir darunavir. And sometimes I'll use dolutegravir rilpivirine, but that makes me a bit cautious, especially if I am unsure about the person's adherence. That I am awaiting dolutegravir and doravirine data in end-stage renal disease and dialysis. That if patient, provider, and clinic can access Cabenuva, I would like to use that. And then if on HD, because I tend to prefer single tablet regimens, I tend to use Biktarvy. So causes of creatinine elevation are multifactorial and sometimes tough to figure out. To consider use of a cystatin C when working up a creatinine rise. That fixed dose combinations are pretty tough to use in renal failure unless you're being placed on dialysis. To use Appendix B, Table 12, and that each clinical scenario warrants different considerations for ART choice in renal failure.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.